exciting episode on LinkedIn Live, the OIG files, not to be confused with the OIG roundtable that we do every week and we put in our newsletter. But today, myself, Eric Rubenstein, I'm the Senior Director of Litigation, Fraud, Waste, and Abuse Support. I'm joined with my dear friend, professional colleague, Jaysen Eisengrein. If you remember Jaysen is a retired OIG member of the senior leadership, retired, went on to run the Medicaid integrity contracts for 34 states on behalf of CMS. And then most recently was the Western UPIC director. And for those of you that don't know the vernacular of a UPIC, Unified Program Integrity Contractor, it is essentially one of the SIUs for Medicare, is the easiest way to put it. So today, for the next 30 minutes or so, Jaysen and I are going to be talking about hospital fraud. Now, hospital fraud has been on and off in the spotlight, dating back when I was hired in the mid-90s. I was hired as part of something called Operation Restore Trust, which was a way that the government was looking to beef up healthcare fraud investigations, primarily as a result of the Social Security Administration and HHS bifurcating as organizations. Social Security went out on its own in 1995 to become its own organization with its own commissioner, and HHS-OIG then had to bolster its ranks by hiring a bunch of people, both for investigations, audits, and regulatory work. And Operation Restore Trust was part of that. But when Operation Restore Trust was passed, it had a very specific mandate that the work of anybody that was hired during what was known as ORT was relegated to working only cases in the Part A world. So in the Medicare world, there's Part A, Part B, Part C, or Medicare Advantage, and Part D. And Medicare Part A, which is hospital insurance, that's the portion of insurance in which there are no premiums paid by beneficiaries or patients. That's the part of the program that's actually going broke faster than Part B, because Part B actually has some money that gets put in through premiums that are used as offsets through Social Security. But hospital fraud is a rather pervasive thing. It's a little bit difficult and at times a challenge to investigate and work with, because most of the fraud that comes in the hospital setting comes out as the result of cost reporting frauds. And for those of you that don't know what cost reports are, they are essentially the functional equivalent of a tax return for a healthcare conglomerate that would be submitting a claim through its yearly capitulation of numbers and things of that sort. And what typically happens is at the end, it's no different than a tax return. The hospital in question or the facility in question that files the cost report, they outline what they got paid versus what they feel they should have been paid. And there's a reconciliation. So we're seeing that hospital frauds have never really gone to the wayside. They're actually, I think, a little bit on the uptick through some sort of nuanced things. We're going to talk a little bit about some of the inpatient DRG stuff. We're going to talk about the outpatient. Most notably, there's currently a situation going on where a particular congressman from a northeastern state wrote a letter seeking the government to investigate and intervene in some allegations regarding some systemic fraud that's coming out of what is, I believe, the largest or one of the largest for-profit hospital chains that owns and operates somewhere around 200 hospitals. And so there are some allegations of fraud, waste, and abuse that this one particular congressman is alleging. And so it is something that remains in the forefront. There's a lot of money, obviously, in the facility side of it. But so Jaysen, I want to turn this over to you, and let's talk a little bit about that landscape and things like the zero hospital stays and inpatient, outpatient, and things of that sort. And particularly when you were running the UPIC, there was a lot of that was going on in your investigative purview. So I want to turn it over to you to talk a little bit about that landscape and what you see as being kind of the hit list of areas of concern.
Okay, before I go on to that, though, I'd like to just set the stage a little bit. So, hospital environment clearly is different than certainly a fee-for-service, standalone provider someplace. It's a system. Most hospitals now are part of a system. So that does complicate it. As Eric talked about, cost reports, those are accounting documents. He used a metaphor of a tax return. So, there are layers and layers of data in there. So to find where the fraud, waste, or abuse occurs requires considerable amount of effort. And certainly coming from the Office of Inspector General in my early days, I think I was referred to as a bean counter on occasion. People would ask, well, where is your green eye shade and your sleeve protectors that, from the ink on paper? All those funny isms aside, the point is that it does require a significant amount of effort. So one of the things is like, is it is it important? So certainly, if in the area of things that would drive the level of importance of a concern, is there patient harm? If that's the case, it really doesn't matter whether it's the fact that they didn't really supply the number of Band-Aids that they've billed for instance. But if there wasn't patient harm, then you have to look at, well, if you start doing all this effort, is there going to be a return on the investment? And so that does get complicated. Now, in terms of trying to prove the 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 matter that you're looking at, obviously, if you think it's going to be a criminal matter, are you going to be able to prove beyond the reasonable doubt that there was intent to um, commit this fraudulent act? So the likelihood of investigators and auditors finding some sort of discrete memo that said, that from the hospital administrator that, yeah, I've got this new illegal billing scheme that I'd like to deploy. It's going to be great for all of us. We're going to make a lot of money. And yes, there are penalties associated with it. So obviously, those types of that type of evidence, we'll say, is probably few and far between. But can you prove a civil fraud case? So something in a preponderance of evidence, is it likely that this was fraud and abuse? Is there an administrative action that is possible? And same level of proof basically, but probably of a different character. Long and short of it is that there are different ways to attack it. And so Eric referenced a couple of schemes. I'll just say that, many times when hospitals are being considered, you know, presumably, one is thinking about their hospital as a place that they trust, and is it really likely that this really illustrious institution, has committed a fraud or is engaging in waste or abusive practices that need to be mitigated in the fashions that happen in the area of program integrity? Well, maybe, maybe not. The reality is that at one point, as the Medicaid integrity contract, we looked in a relatively small states hospitals, and there were, I think, 11 hospitals in the state. And what we were looking at is 0 and 1 day stays. And what a 0 or 1 day stay is that somebody, that's probably of a certain age, maybe of a certain weight category, maybe have other comorbidities. Let's say they had tacos on Friday night, and now they're having indigestion. And because of whatever category they fit into, they decide, you know what, really, we have to go to the ER and get this checked out. And, obviously ERs are pretty busy. You're put on a machine, you're, given some initial triage and triage related equipment. And the reality is that, that goes on for a certain amount of time. And whether it was purposeful or not, it's long enough where it ends up being billed as an admission as opposed to just an outpatient category. And when we looked at all 11 hospitals in this particular state, all of them, had confirmed violations of that. So, it there wasn't anything that would rise to the level of a criminal violation, that there was some intent to defraud um, Medicare in that case, or Medicaid. That, but was there, an abusive practice? Maybe so. And in fact, there were findings of that. So it is something that is deep, but and requires effort, but it can be widespread enough where you really need to be taking a look at it.
So it's interesting because you talked about how, really these 0 and 1 day stays initiate in the emergency room. I can tell you what we're seeing on the SIU side here is a large uptick in cases that we're working with our SIU team and our payer partners on emergency department visits, that there has been a steady increase in emergency department groups routinely submitting claims seeking payment for level 4 and level 5 evaluation and management codes, which, in general terms, a level 4, you've got to be pretty close to dead, and a level 5, you got to be dead. As far as how severe your case is. And, we're seeing a lot of these cases come in where we're doing these reviews, and we're seeing sort of systemically emergency department groups are billing level 4 and level 5 pretty consistently, but the documentation really doesn't come close to supporting that level 4 or that level 5, when under the scrutiny of a clinical review. And so it is interesting to see that it's parlaying itself in some regard, that it could parlay itself from being an upcoded claim for an emergency department visit to then a facility claim for the 0 or 1 day stay, right? Because at the end of the day, the provider groups in emergency departments are often contracted. So they're billing for what they believe to be their appropriate service or what have you. A 0 or a 1 day stay is a facility related charge. It's not a provider related charge. And so there's a little bit of that discrepancy. I can tell you that on some of the projects that we've done, we looked empirically at data and found some instances where the facility was billing for a level 3 and the provider group was billing for a level 5. And so that immediately is a non sequitur, because those two should be coming together. How is it that the provider is saying that this is a level 5, but the facility is only a level 3? When you look at the documentation, there's nothing in there that really says that one, we don't know which one is right, which one is wrong until you get the documentation and you start to look at it. But we're seeing this as a trend. Now, I want to go sort of to parlay this into when we start talking about facility related charges, that typically when the patient gets admitted into the hospital, it falls under the DRG, the diagnosis related group. And for people that aren't inordinately conversant in that, the simplest way to put it is if a patient got admitted to a hospital for pneumonia, most insurance plans, and we'll talk about Medicare in particular, pay a sort of a flat amount of money. If your diagnosis is pneumonia and you stay in the hospital for 3 days or 10 days and it's just sort of pneumonia, you get that amount of money, and there's no sort of vacillation in that, generally speaking. And the point of that is that as a cost containment perspective, you're not paying for things kind of in an a la carte world, but also it is then in the facility's best interest to get you out of the hospital as quickly as possible, right? Because for each day that you spend in the hospital, it costs the hospital money. So if they can get you out in 3 days versus 7 days, they open up that bed, they have the ability to turn the bed. And, not that I want to make this an analogy, but it's almost like a hotel, right? A hotel wants to have the beds full all the time with fresh paying customers. If you're in the hospital for 10 days and you're not getting any additional money, you'd rather have that person out and get fresh money. We've done a ton of work in the DRG space. We have about 30 nurses that are currently doing DRG work right now on the payer side and the appellate side and what have you. But we did a project a while ago for a particular payer involving DRG for sepsis. And what we found was a 75% error rate. Now, this was not a statistical sample. We looked at kind of a probe sample provided to us by the payer client, but we found a 75% error rate where all of these were for sepsis claims. And in 75% of the instances, the patients did not have sepsis. There wasn't a diagnosis of sepsis. They had a UTI, urinary tract infection, respiratory infection, bronchitis, something like that. It really hadn't risen to the level of sepsis. In a lot of cases, the patients were being admitted and then discharged 2 or 3 days later. And there's some criteria for sepsis involving what they call the LOS, or length of stay. So, these kind of issues are pretty prevalent. on our DRG team, we're seeing a lot of that even now. But this kind of always begs the question, and we were talking about this a little bit earlier, is about lowering reimbursement rates and Deficit Reduction Act and sequestration and all of these things that have led to flat payments, greater scrutiny from the payer side, and the like, which is causing smaller community hospitals to have to shut down. So let's talk a little about that, Jay. But what do you think? Like, what are the effects that wind up happening from it's kind of this cause and effect, right? Like, so the payer community gets more scrutinizes claims a lot more, and clawbacks occur as a result of that, which then affects the bottom line of the facility, which then results in the potential of them to have to go bankrupt or close and things of that sort. So there's almost this like push-pull, right? About like, what do you do? You're on mute there, Jay.
Sorry. I think we need to start with some of the basics and the attributes. So you mentioned community hospitals. One of the things that always has to be considered is, okay, if there isn't patient harm, which I said always makes, puts a red flag on any item, but if that's not the case, then you have to think about, like, are you inhibiting access to care? So in a community hospital setting, if it's in a rural part of a state, it might be the only healthcare in that area. So, you know, there are going to be additional sociological problems, frankly, if you start closing down community hospitals because they can't bear the weight of that kind of scrutiny. The other thing is that, are you looking at the facility, or are you looking at the provider? Because as you said, Eric, there might be situations where the facility is just um, unwilling conspirator, right? It might just be that a provider is utilizing a hospital setting for their own use. And so, it might just be that they're an unwilling victim, if you will, of the situation. But nonetheless, again, fraud, waste, and abuse, especially fraud and abuse, they really fall into one of three categories, in my humble opinion. First, and at the top of the list is usually a billing for a service not rendered. Was it just outrightly, something that they didn't do? Second would be some sort of misrepresentation of the service. So it could be an upcoding, and is probably the most um, glaring example of that, or it might be an unbundling in certain diagnostic tests. And then the last being, and most difficult to prove, frankly, are unnecessary services, because it falls into the category of a battle of experts. So, you have to look at those basics to decide, is this a matter that's worth pursuing? But I would just say that knowing what the problem is and whether or not it rises to the level of a serious mitigation that could lead to some closure, that could lead to some recovery that the facility can't bear, it's better to know what it is than to not know.
Yeah, I think when we're talking about things like the DRGs and all of that, it's hospitals have their internal staff, what they call the CDI, clinical documentation improvement staff, and there's about 100 different certifications that individuals can get, both from a documentation perspective, and then if you're doing clinical validation and the like. And one of the things that I've gleaned from our team, and we've got a medical doctor on our team who does a ton of clinical documentation improvement related training and education. She's one of the authorities in the space, and she's doing a project right now. We're doing a 100 claim review for a payer on readmissions. And these were readmissions within 30 days. And so the question that the payer has is, are these readmissions for a lack of care? should these people have been discharged or not discharged? And while for the most part, it appears that the readmissions are for entirely separate instances, the one thing that our expert has been opining about is just the level of overall quality. And she does indicate in a lot of instances that the poor quality is the result of EMR systems, and the fact that EMR systems just carry over information from one to another, and providers don't really have the opportunity to change or move or delete, things that aren't carrying over from one thing to another. But I do think that when we're talking about the fraud piece of it, you hit on this in the beginning. And by the way, for those who didn't catch our OIG Roundtable podcast, you should go back and take a look at that afterwards, because we do talk about that, the intent issue in our podcast that we did as part of our OIG Roundtable, which you can get off of a link from our newsletter. But we talked a little bit about that at the OIG Roundtable about this issue of intent. Back in 2004 and 2005, I worked on the case that at the time was fairly notable. It was the University of Medicine and Dentistry of New Jersey, which was comprised of something like 9 different medical institutions. It was the state-run medical school. It also comprised University Hospital in Newark, and was ultimately a cesspool of fraud, waste, and abuse from a billing and coding perspective, but also from a public corruption perspective. And you talk about the intent issue. Ultimately, UMD and J signed a deferred prosecution and got a federal monitor put in place. And as a result, we identified some more cases involving kickbacks to cardiologists. But what led to UMD and J's original case was what they called the 1122 issue. 11 meaning facility, 11 meaning provider-based office, 22 meaning facility-based, and there was a double billing issue. And ultimately, what was uncovered was that there was clear communication between the parties about who's responsible for billing. And when you talk about intent, the CFO at the time, whenever it came time to sign the cost reports, he would take vacation and have one of his underlings sign the cost reports, because he didn't want to sign the cost reports knowing that there were issues. But outside of something as glaring as that, you don't really see the criminal prosecution of facilities. And I think that, you hit the nail on the head. A lot of that is the socioeconomic piece of the puzzle. If you are a rural-based community hospital, or you're in an underserved urban area, how do you criminally prosecute a hospital and then they're under the mandatory exclusion? And most of these hospitals are dealing with indigent populations. They're getting payments through charity care, what are known as DISH, right? The disproportionate share hospital payments, Medicaid, and the like. So, you often see instances where fraud, waste, and abuse is occurring, and you have to take some alternative method. But what do you do in an instance like that, right? How do you rectify the malfeasance of a facility that's in an underserved community?
Well, first I want to comment on your point about the administrator taking off to not sign the report. So I think it's important. I'm going to ask you this question: was that an evidentiary fact that was brought up? Because a pattern is a pattern is a pattern, and that's what investigations are about. The fact that you always took off is, potentially an indicia of guilt, and intent.
So it wasn't a one-off thing. And the fact that I remember it having occurred, 19 years ago, it was a fact. And what was interesting was a number of people in the finance department had provided that as information. Like, we always knew there was something wrong with these cost reports, because the CFO always took off during the week that the cost reports had to be signed, and made some overtures about taking vacation. I'm not signing those cost reports.
Interesting.
So get back to, so the question really is, what do you do when you've got a hospital that's engaged in some sort of malfeasance? I'll give you as a great example, the review that we did, where we found a 75% overpayment. It was for 2 or 3 hospitals that were in very urban metropolitan areas where the largest percentage of the population that was being treated, the census of the hospitals, was Medicaid. And so if we actually did a full-blown statistically valid audit on each one of these hospitals, we likely would have identified some inordinately large amount of money that no hospital would have been able to pay back, particularly an urban hospital that's relying upon dish payments, Medicare, Medicaid, and grants. And it's like, you're a little bit of a rock and a hard place. Like, what do? They're committing waste, fraud, or abuse. And, I think this becomes one of the challenges. And we talked about this in our OIG roundtable on SIU related functions and OIG functions from an investigative perspective. It really does beg the question of, does somebody care? Or is somebody willing to negotiate a settlement agreement based upon, if we're talking about the OIG and OSIG and U.S. Attorney's Office, ability to pay, and it becomes 10 cents on the dollar, and there's been a lot of money paid? Or is it, do you really look to put, so to speak, put the screws to the organization to set a message to the rest of the community? I think it's a really interesting, like, medical, ethical, psychological, economic conversation.
Well, you probably were asking what do you do rhetorically, but I will, I will answer the question in that you still conduct your investigation, which will really, and it could easily be an audit rather than an investigation, but if it's an investigation, it'll definitely have audit components, uh, because you're going to need to use statistics. So having a statistical analysis that can withstand the rigors of some test, whether it be a legal or an ethical test. And then you also need to have auditing principles that are aligned with government auditing standards so that, again, the findings can withstand the rigor of those tests. But ultimately, information is power. So whether it's going to result in a prosecution, civil or criminal, or an administrative action, or simply a dollar, a dollar for dollar reimbursement, it's just important from many aspects. Number one, as I said earlier, certainly if any of these services related to patient harm, you got to know, as an institution, as an oversight organization, or whatever. And what I'll say is what's also going to be really important along with those auditing principles, statistical analysis principles, and things like that, is just what you mentioned, Eric, having that clinical expertise available to marry that to the investigative and auditing processes is crucial. So, having, a doctor, nurse, pharmacists, other clinicians that, would be familiar with the services, and preferably in a like licensed field would be very useful.
Yeah, I think that's a great point. You know what? One of the things that I found interesting was I recently had a conversation with a few of our DRG nurses, our clinical validation nurses, who all came at some point from the provider side. So they all worked on the CVI, clinical validation side, and are now working for us doing reviews, prepay, payment integrity. And I've asked them, what was your opinion before and what's your opinion after, as far as the payers? Whereas, they always believe that the payers were the big bad wolf, and why did they deny? And they actually said, now that they're doing it from the other side of the coin, they really did learn that there were so many opportunities that they were missing, or so many things that they weren't doing, had they just understood either the policies better, or they just had better direction, or really it's a training and education issue. Had the providers that were documenting been better trained on how to do the documentation? And our MD, that's what she does. She's a clinical documentation improvement person, and that's all she does really, is provide opinions, training, and education on the quality of documentation. And so oftentimes I think it's a penny wise, pound foolish. And I say this a lot in the provider world when it comes to following the OIG's model compliance guidance, right? One of them is self-audit and a compliance committee and all these. Some of these things are not things that the provider community needs, but others really should. And I think if you're going to be a penny wise and a pound foolish and say, well, this person has this clinical certificate for documentation or whatever, that, oh, that's good enough, that there is a failure of the, sort of the overall industry to provide continued and updated training and education. Providers are busy. They don't have the time for these things. And, a lot of them are, you can't teach an old dog a new trick. They just want to be able to do what they have to do. So it really is a challenging environment. But I think it ultimately comes down to that you have to be vigilant, right? The provider community has to be vigilant to make sure that what they're submitting is accurate and correct. And if they are in a position where they're seeing a lot of denials, a lot of appeals being denied, are they doing things to make those teaching points? I once had someone say to me, even bad training is good. It wasn't you, by the way, who said that, it was someone else, but said bad training is good because it teaches you sometimes what not to do, right? And so I think that there's obviously opportunities for improvement. I think that there's opportunities for the community to learn from the errors of others, because as I've often said, and we say here quite often, is the clowns may change, but the circus stays the same. So the fraud schemes that are out there are going to continue to be out there. But so to close out, give me some predictions. Where do you see the resurgence of fraud, waste, and abuse in the hospital setting continuing, or do you see it kind of leveling off just because there are so many hospitals that are at risk of closure because of funding and related issues?
Unfortunately, I would say that after 43 years or so of being involved in this marketplace, the sands just shift. Ultimately, people that have ill intent or are operating with less than the full range of abilities or competencies that they should have for their various positions, it's probably just going to move around. And that's why a full-fledged compliance program that you referenced is really important. That entities and individuals are looking and self-assessing, even when there isn't a complaint, to see the various areas that need process improvement. And that's, I mean, Eric, we were speaking earlier, and the idea of oversight in that area is that you can mitigate as many nonconformities as possible, identify opportunities for process improvement that can be helpful, and to replicate the things that are the best at what the organization or the person is doing. So you're only going to get that, like I said, through getting information. Information is the power.
Right. I think that's a good closing point. So, well, it looks like we're out of time. So I want to thank everybody for joining us for this LinkedIn Live Learning Edition on hospital fraud. Again, if you have any questions that we didn't get to address while we're sitting here talking that weren't kind of self-answered, feel free to send us an email, hello@advise, ADVIZE, health.com. If you're not getting our newsletter, you can send an email to us at that same email address. We'll get you on our weekly newsletter, which has links to all of our podcasts. You can also get us on our YouTube channel. Just go into YouTube, look for Advise Health, and you will find all of our podcasts. We're also on Spotify, Audible, and a bunch of other audio-related podcasts you can download and listen to us pontificate during your drive, if you actually drive to or from work, because most people don't do that. But I do find that when you're on a 10-mile run on your treadmill, listening to us pontificate is always an amazing way to at least deafen the pain of a 10K or a 10-mile run. So thank you so much for joining us. We look forward to seeing you on our next LinkedIn Live.